Hello, and welcome to a further lecture in the Masterclass in Foot and Ankle Surgery series. For this lecture, we're going to be concentrating on looking at ankle instability. And we're going to be looking at both lateral ligament injuries and the so-called high ankle sprain or syndesmosis injury. So these are common injuries. There are nearly 1 in 10 of all patients who attend the emergency department. They're a quarter of all musculoskeletal injuries, and the vast majority of them are related to sport. So it's estimated that worldwide there are 1 in 10,000 people per day who experience a lateral ligament injury or a syndesmosis injury. So that adds up to a pretty substantial number of injuries over a year. Obviously, there is quite a range of injury that's sustained, from a simple overstretching or a grade 1 injury of the ligament through to a grade 3 or complete rupture of 1 or more ligaments. In the vast majority of cases, it's the lateral ligament complex that's involved. About 10% of injuries, however, are syndesmotic injuries, and it's very, very rare that a pure medial deltoid ligament injury will occur without injury to either the syndesmosis or the lateral side of the ankle. And we must bear in mind that these are not only soft tissue injuries, but they can also be associated with bony injury and cartilaginous injury, and also with bone marrow edema, particularly within the talus. So what are the aims of our treatment? Well, we want to prevent early problems, and these will essentially be pain and swelling. We want to decrease those, and we certainly want to eliminate potential late problems, particularly of chronic pain, recurrent instability, the recurrent instability causing osteochondral lesions or other soft tissue pathology, and further down the line, the possibility of a varus ankle creating an instability type medial sided degenerative change. So what are the mechanisms of injury for these ligamentous injuries? Well, as we all know, a lateral ligament injury tends to be an inversion injury. It's excessive supination of the hind foot on a plantar-flexed foot. The ATFL, which is the weakest of the 3 ligaments, is injured first, and with further force, the CFL will also become injured. It's very rare for the PTFL to be injured also. So if we're looking at the mechanism of injury, then have a look at this video clip, because this demonstrates this quite well. So if we look at the player wearing red number 9, and we keep an eye on his right ankle, we will notice that as he steps, his ankle goes into plantar flexion and inversion. The mechanism of injury for a high ankle sprain or a syndesmotic injury is a different mechanism, and that is usually a combination of external rotation of the foot and hyperdorsiflexion at the ankle. The AITFL is usually injured first, followed by the interosseous ligament, and subsequently the PITFL. The AITFL is the primary restraint to external rotation. The deep deltoid is a restraint to external rotation and lateral translation, and may also be injured with this mechanism of injury. The PITFL is a restraint to posterior translation, and the interosseous ligament is the restraint to lateral translation. So again, we can see this in a further video clip. If you look at the player in white who's going to receive the ball, And again, keep an eye on his right ankle, particularly with the slow motion section. You will see how this mechanism of injury is demonstrated. However, it's unlikely that we'll all have the ability to see how injuries have occurred on television or on video clips. And usually we'll have some sort of scrawled message from our emergency service doctors saying that the ankle is bruised, swollen and tender with a decreased range of motion. They've diagnosed a sprain and they've told the patient to rest, ice, compress and elevate, and they've referred the patient into the trauma clinic. So not always particularly helpful, but often by the time they come to present in our trauma clinic, things will be a lot more clear-cut, enabling us to make first a clinical diagnosis and then possibly organize more investigations if necessary. So we need to work out what structures have been injured. Are there any predisposing factors? And is there any associated pathology? So this is a landmark paper, a fantastic anatomical dissection from knee surgery, sports traumatology and arthroscopy from 2010. And this gives you a great indication of where the origin and insertion of individual portions of the ligaments are. This is important, particularly when trying to palpate during clinical examination, but also appreciation of structures on further scanning, particularly MRI scans. And also if these patients are coming to surgical reconstruction, it gives you an idea of where the relevant structures are that may need to be repaired. So I would highly commend this paper to you. So when patients appear in clinic, we need to take a history and examine them. So we can ask about the injury pattern. Often patients will know, particularly if their ankles have gone into inversion, and particularly if they've done this before. Assessing the pattern of bruising is also very beneficial. In patients who have a lateral ligament injury, the bruising is often just localized to the lateral aspect of the hindfoot. In patients with a syndesmosis injury, this may extend further up the calf. We want to know if they were able to weight bear or are able to weight bear, and have they injured this ankle before. And we also need to decide when is the best time to examine these people.